In this headache lecture, what you need to be able to do is recognize when you need to pursue more invasive diagnostics, that is, identify red flags for secondary headaches, and when you can just use the history and physical to make your diagnosis, that is, the absence of red flags and primary headaches. Most of this lecture is going to be dedicated to the primary headaches because the secondary headaches are taken care of in their respective sections. So what I want you to see is when someone presents with a headache, the first thing you need to do is ask, are there red flags? Because if there are red flags, then you're in the world of secondary headache. And secondary headache is going to require some intense investigation. You might do some components of a CT, lumbar puncture, and/or biopsy. I'm not saying that all of them require all three, but in some form or another, you're going to get these type of testing to find out what's going on. And you're going to do things like brain bleeds, subarachnoid hemorrhage, tumor. You'll learn more about this in the surgery subspecialty, neurosurge. If there's a fever and a headache, with some focal neurologic deficit, you might find an abscess or meningitis. These are discussed in the ID brain inflammation lecture. But there is one in the secondary headache section that I do want to talk about, and that's going to be idiopathic intracranial hypertension. I'll come back to this after we've discussed the primary headache diseases. Of course, there's more to it than this, right? There's going to be things like rheumatologic autoimmune cerebritis and some other stuff that gets thrown in there. But what I want you to be able to recognize is going to be the brain bleed, worst headache of their life, the tumor, focal neurologic deficit, progressive nausea, vomiting, abscess, fever, headache, and a focal neurologic deficit, meningitis, fever, and a headache, and then know what to do next. And you can learn more about that in their corresponding sections. So then what are these red flags? So we've said a few of them already. If you have a headache and a fever, or a headache and a focal neurologic deficit, that's a no-brainer, right? Either you're going to lumbar puncture that person or CT them based on the safety of the Fales mnemonic. Check out brain inflammation for more details. But some stuff you might not think of right away are going to be things like the new onset headache with an age greater than 50, or the thunderclap headache. The thunderclap headache being the worst headache of their life that comes on all of a sudden, that's rapidly crescendo to maximal intensity, usually preceded by a sentinel event. And lastly, the thing that represents cancer is progressive nausea and vomiting, usually worse in the morning. So if you have any one of these, you're in the secondary headache section, work it up. If you don't have any red flags, then you're in the primary headache section. Now all you need to do is use the history and physical to figure out which one it is. And you're going to have to decide between one of four diagnoses. Tension, analgesic rebound, cluster, and migraine. Let's talk about each one at a time. Tension headache is the most common headache in America. It is essentially muscular pain. This is the headache that you've had many times before. You wake up, you didn't sleep well. Maybe you drank too much last night. The neighbors are partying too loud, you're trying to study. You're stressed out. Your head hurts. It's the headache that you use over-the-counter medications for whenever you have a headache. Right? Lots of people have this. But you as a physician won't see this complaint because the patients just take care of it themselves. But what you should look for on the test is a bilateral vice-like pain that starts in the front and radiates to the neck. It's often exacerbated by loud sound or by exercise, but there's no real photophobia or phonophobia. The diagnosis is clinical, and the treatment is with over-the-counter medications. NSAIDs or acetaminophen. The patients generally pick for you. Now, analgesic rebound is essentially a withdrawal symptom. And there's rigid criteria for who could be actually diagnosed with analgesic rebound. But what I want you to feel is that if you've used caffeine multiple times per day, and then you stop and you miss your cup of coffee in the morning, you have a headache. That's analgesic rebound. But analgesic rebound specifically refers to people who take medications for their headache, like those that contain opiates in particular. So people who use pain medication, it can be NSAIDs or acetaminophen or the stronger stuff, and they use it often. If a person uses analgesics, especially those who use triptans, butalbital, or opiate compounds, more than 10 times per month, these are the patients who are at greatest risk. It can be acetaminophen and NSAIDs. They can get headaches a lot every time they stop their medication. This is a clinical diagnosis also. And you actually need to treat them like they are addicted. Let them withdraw. Yes, it hurts. It actually sucks, but it won't kill them. They just got to get off those meds, suffer for a couple of days, and the headaches will resolve. Now, where you're going to get the most questions, I think, are going to be on cluster and migraine. Cluster is really representative of a series of diseases that are separated only based on their duration and frequency. The longer the duration, the less the frequency. That's cluster headache. And the reason why I want you to learn cluster is because they last long enough for you to actually make a diagnosis and do something about. Headaches that only last a couple of seconds but occur thousands of times per day are useless because you can't do anything about them. You can't intervene on behalf of the patient. The pathology of cluster headache is vascular. And the patient is generally going to present in a very clear clinical way. They will be asymptomatic for months. And then all these attacks will cluster together, thus the name. They'll happen 8 to 10 times per day, and they have the same attack every time. You're going to see unilateral eye pain associated with Horner syndrome. You're going to get rhinorrhea, lacrimation, conjunctival injection. Their lid will sag. Their eye is messed up and it hurts. It's big, red, angry, and irritating. And then it'll go away on its own, but those attacks will keep coming. The diagnosis is made clinically. And the treatment to abort someone in an acute cluster attack is to use oxygen, which is why this is a favorite board question. All you do is put them on some nasal cannula and their headache goes away. If that doesn't work, second line are the triptans. Do subcutaneous sumatriptan and you can abort the headache. But people probably don't want to get into the situation where they have to throw on oxygen all the time throughout the day to abort their headache. So what you can do is prophylax with calcium channel blockers like verapamil. And the thing about cluster headaches is that it is the only one of the primary headaches where you should do a one-time brain imaging. CT or MRI being preferred because of the better resolution, to make sure you don't have something else, that it really is a cluster headache. Compare cluster to migraine because their pathology is similar, we think. Vascular, generally vasodilation. But the patient is going to present very differently. They're going to have a unilateral pulsatile headache. That is debilitating. Debilitating in the way of photophobia, phonophobia, and nausea and vomiting. They may have an aura. And this is where it gets tricky, because that aura used to be like a seizure, but now it could be any focal neurologic deficit. It can be literally anything, and it gets a different modifier, some sort of migraine, based on the aura they have. But almost always, migraines have a trigger, and people know what their trigger is. MSG, the menstrual cycle, chocolate, caffeine, and they tend to avoid it. Although if they're exposed, they know their migraine's coming, so then they get prepared. The cool thing is if they manage to sleep, they will abort. And the next day, you'll have a hangover. But if you don't abort it, they could last anywhere from 4 to 72 hours. If you meet the criteria for migraine, no additional work needs to be done. The diagnosis is clinical. When someone is in acute attack, you have to decide how severe it is. Mild cases get NSAIDs. In fact, NSAIDs is the preferred first-line therapy for all migraines. Get ahead of the migraine, give the NSAIDs early, get through it. For moderate to severe or refractory to NSAIDs, you should use triptans. Ergots are okay too. Be careful of using triptans and ergots in coronary artery disease because these cause vasospasm. Butalbital compounds should be avoided. Fiorcet's an awesome drug. People love to use it, but medically and on the test, you should avoid that stuff entirely. Just like the cluster headaches, we do have the ability to prophylax against migraines. You want to use beta blockers like propranolol or anticonvulsants like valproic acid or topiramate. And if you have clearly diagnosed migraine, you don't need to do any brain imaging. Okay, so for the primary headaches, you're looking at tension, analgesic rebound, cluster, and migraine. Pay most attention to cluster and migraine. Cluster responds to oxygen and triptans. Migraine responds to NSAIDs, triptans, and or ergots. Prophylax cluster with verapamil, prophylax migraine with propranolol, or anti-seizure medications. Cluster needs imaging, migraine doesn't. What I'd like to close with is the form of secondary headache, idiopathic intracranial hypertension. And the pathology is in the name. They have an increased ICP, but for no reason. The patient is going to be a woman, and she's going to have the signs and symptoms of increased intracranial pressure, especially papilledema. But look for focal neurologic deficit, nausea, vomiting. But because you have all of this, you're like, oh my God, something's going on in their head. They must have a tumor. This is also known as pseudotumor cerebri. It's going to be a negative CT scan. Lots of things can cause it, but for some reason the board loves to go after the association with OCPs. Check out other reasons. There's a list in your notes. And if you get to the point of there is increased intracranial pressure, I saw it in her eyes, and she has a negative CT scan, you're going to find the answer by doing a lumbar puncture. What you'll find is the opening pressure is greater than 25 centimeters of water. Very high opening pressure, and there's relief after you do the lumbar puncture. You don't have to do any more imaging other than the CT scan because now you've got your diagnosis. Treatment, first-line therapy, is going to be with acetazolamide. But refractory cases, or while the medication gets going, might require you to do serial lumbar punctures. And if all else fails, you'll need a VP shunt to decompress. And I'll just bring it up here now because sometimes it gets discussed in the setting of headache, even though we talked about it in seizures. And that's trigeminal neuralgia, the lancinating pain that goes down the jaw from the ear to the chin. whenever someone ingests cold water or chews on ice or starts eating. That's essentially a seizure of the trigeminal nerve causing face pain more than headache. That's treated with carbamazepine. Versus the 5 diseases of this lecture: idiopathic intracranial hypertension or pseudotumor, migraine, cluster, analgesic rebound, and tension headache. That's headache.